we'll wait till the partition is opened. But thank you to the organizers also for switching to the title slide. Before that, it seemed I was like this faceless, nameless guy, no designation, no honors, awards, accomplishments. And again, considering what you've seen right now, it's it would be an understatement, of course. So we'll just wait a minute as per Dushyant's instruction, then we'll go ahead. Just waiting for the time to get updated. I think we're just waiting on that. All right, perfect. So we'll just breeze through this quickly, and of course, this is a topic which is relevant yet evidence insufficient. So we'll try to extrapolate something from data, very little from our personal experience, because again, this is a disease that we see less of compared to DTC especially. We'll talk about management of the neck and medullary, and of course, hopefully we can encourage a lot of discussions. So medullary is an uncommon cancer, but we know its node metastasis predominant. Most of our medullaries that we see are going to metastasize micro or macroscopically. This is some data that we looked at, and interestingly, we are seeing about 11% of our thyroid cancers being medullary, which was a surprise, but then again, this is older data, and over time, it's remained roughly between 8 and 10%. When you look at medullary, of course, before we start with the neck part, it's important that there are some caveats to interpretation. The latest guidelines can be called dated. We have distinct subtypes in terms of genetics and morphology, which make extrapolation non-feasible. So we have to essentially extrapolate from our personal experience and from the experience of others, including those in the audience. There's a gap between clinical manifestation and onset of disease. Data is retrospective, and resource availability in terms of all the isotopes that we sometimes use can be limiting. But again, for the surgeons, because this is a conference of predominantly surgeons, terminology is important. It's important especially for the youngsters to know that one paratracheal lymph node basin does constitute a central node dissection. So it's not obligated, not only in medullary but in DTC, to actually go to both compartments. One constitutes a central, but you have to clear the entire pre-laryngeal and pretracheal components. Someone talked about TG washout in another hall. It's interesting that FNA alone is not going to be diagnostic. You need serum studies, and you also might consider IHC on an FNA specimen as well as a calcitonin washout. And there are no randomized trials, but there is interesting data which says that you can probably test serum calcitonin in all nodules more than 1 centimeter, and 1% of those patients are going to be medullary. But it's a recommendation I, which means indeterminate currently. What happens when you do get a proven MTC? You have to do germline red testing. In hereditary variant, more often than not, you'll end up taking up these patients for surgery, so a FEO has to be ruled out first. In order of preference, the FEO has to be treated before either the PHPT and the medullary. Whenever you have a calcitonin less than 500, this is a broad generalization. There's a less possibility of metastasis. And of course, the ultrasound is baseline. I saw Dr. Bal make a comment in another hall that ultrasound is going to pick up per disease in the vast majority of the patients. There's data backing that. But if you look at other sites where medullary typically involves, there are modalities that are specific to all of them. Given our country, we might not be able to do everything in everyone, given resource constraints, cost constraints, but you want to apply it to patients, especially whose calcitonin is going very high. Coming to neck, in palpable MTC, roughly 3/4 of medullaries is going to go to the neck. And essentially how you do neck management is going to depend on your ultrasound as well as your calcitonin level. The calcitonin level the incidence is high in contralateral neck whenever the ipsilateral central compartment is positive. It's questionable whether it's irrespective of size. Some data says less than 1 centimeters and more than 4 centimeters have an equivalent risk of metastasis. Most of us would probably disagree. Personal experience would typically show as the medullary grows, you typically have more metastasis in the neck. And intraoperative assessment is unreliable, of course, especially of the lymph nodes. Here we're only talking about central compartment. So what are the take-homes from this? Is the most important slide of the presentation. When you have a calcitonin basal, of course, that's less than 20, there's a negligible risk of central compartment nodes. And again, generalizations, but supported by evidence. When you go over 20, you expect disease in ipsilateral central compartment and the lateral compartment. More than 50, you're thinking of contralateral central compartment. More than 200, contralateral lateral compartment, even though it's a grade C recommendation. And more than 500, you're typically looking at metastasis and or upper mediastinum. It's important, of course, all of us know that affecting a biochemical cure in medullary is more challenging than affecting a clinical cure. Biochemical cure with compartment-directed dissections, when you address it in this order that we talked about, is still possible in calcitonin levels in the hundreds, but in the thousands, it becomes increasingly challenging. Not necessarily that you're trying to affect a biochemical cure, but it's an indicator of your response to therapy. Also, because calcitonin forms such an important part of our decision-making with regard to neck, elective as well as therapeutic, we need to know how we are testing them. So this assay is typically more sensitive. Pentagastrin stimulation is more sensitive compared to calcium. Men typically have higher baseline values of calcitonin because there's a higher C cell mass. And of course, in children, especially when you're considering the odd prophylactic thyroidectomy, you need to know that basal calcitonin levels are very high in children less than 6 months of age and up to 3 years of age. And very interesting thing I found was procalcitonin and calcitonin ratio. The higher it goes, it's more prognostic. Even though we don't routinely test for procalcitonin in medullary, it's a different setting altogether. When you look at provocative testing, in the interest of time, because we've just been abbreviated, I'll go over this, but I'll be happy to share the PDF with anyone who's interested. CEA, important to know that in conjunction with calcitonin, it does offer help, but there's a false elevation that we need to look at. And if both of them are low, it does not necessarily rule out medullary. It might actually indicate a bad actor, a poorly differentiated histology existing within a medullary, as well as a high proliferation index. There are proposals for classification. Here, they're proposing N1, N2, and N3 as opposed to the classic N1A and N1B because it has prognostic significance. But when it comes to extensive regional disease, remember that we have different endpoints. When it comes to extensive regional disease, we are looking at giving quality of life to patients, especially when we end up incorporating these structures which are surrounding the central and the lateral compartments, and you might want to consider other therapies. You do individualize these patients because we know less and less about these patients, but hopefully time will show us more. So if the scenario is so pessimistic in calcitonin in the thousands, why do we address the neck? Because there is evidence that loco-regional control is better if you address the neck, even if calcitonin is in the thousands. And there's a decreased possibility of invasion of aerodigestive tract and the recurrent laryngeal nerves, thereby resulting in a better quality of life. So all these intraluminal thrombi and the disease that you see in medullary thyroid carcinoma does need to be addressed, especially if you're not going to resect or incorporate neighboring structures. Beyond biochemistry, staging radiology helps. Simple algorithm, upper pole typically goes to the upper deep cervical, and about 10% of cases it will skip the central compartment. Mid or lower thyroid is typically going to go to the central compartment, so you want to address all upper pole medullaries with some treatment given to the deep cervical nodes as well, regardless of calcitonin. Couple of scenarios, we'll push through this, but sporadic and familial, largely the philosophy of management remains the same. Residual nodes will typically get neck dissections in the same way. And when you look at reoperative neck and recurrent neck, it's important to again know that it's achievable, a biochemical cure, if calcium is in the hundreds. We talked about it again, and you want to start considering more technology, including IOM. Prophylactic thyroidectomy, because of the rarity of the disease, I'll skip. Hopefully Shiva will cover it in the panel, but you want to screen for POs, of course. Last couple of slides on complications. Of course, you know that these are what we face, especially when you go to the lateral compartment, because about half of these patients are going to get lateral necks, prophylactic or therapeutic. And of course, in men 2A versus men 2B, the implantation sites are different. This is our data. We looked at that. Mandar talked about outpatient thyroidectomy in our hall. The top two subsets actually are candidates for outpatient thyroidectomy in our setting. Only if we do a bilateral central compartment do we admit patients. Otherwise, we typically discharge them the same day. Follow-up, I'll skip in the interest of time. And again, isotopes with regard to recurrent regional disease. I think I will have to skip it in the interest of time as well. Last couple of slides. When you do have a recurrent neck, I just put down some single sentence philosophies on how you do. There is an individualized threshold of addressing the recurrent neck based on anticipated cure. So if you think that you're going to cure these patients and it's going to make your follow-up easy and their quality of life better, you want to do the compartment-directed neck dissections. Otherwise, you might end up considering a nidectomy, especially when extensive surgery has already been done in the neck. It will help your locoregional control, and it will prevent your nodes from sticking to recurrence and sticking to major neurovascular pedicles. External beam we'll skip. Last slide. Calcitonin impacts elective and therapeutic management. Do consider stimulated calcitonin, but again, in specific settings. We mentioned that, but like I said, I'll be happy to share the presentation. Radiology and contemporary nuclear medicine, we did not get a chance to discuss isotopes, has definite diagnostic and prognostic roles. Surgical management essentially is tailored on the extent of disease and anticipated cure. And biochemical cure is realistic in per primum disease. In recurrent disease, it ends up being a different thing altogether. I will take 5 seconds to invite you to our next event 2 weekends from now. If all of you have time, it will be great if you can join, at least a few of us. Thank you so much.
Thank you so much, sir.